Take two, because I'm on a tear called Is It Mission and/or Margin? Let's talk about how this goes down when you're in the belly of the beast. Today I am speaking with Dr. John Lee.
American healthcare entrepreneurs and executives you want to know. Talking. Relentlessly seeking value.
I am so focused right now on the intersection, or lack thereof, of mission and margin. So I'm taking a second listen to this episode right now with John Lee, MD, because it is so ridiculously relevant, given that I am, as stated, on a bit of a tear. This mission/margin bender kicked off, actually, if I had to diagnose the root cause, it's because of all of the conversations that happened after what I'm calling the Trust Throughline episode 477. Because if you think about it, and I have, if we are talking about trust, what does that even mean? Like, trust to what end? And when you start distilling it down, you wind up with trust that someone is going to do right by patients and purchasers and the actual clinicians providing the care, that even if there's a stack of Benjamins to be had by doing the wrong thing, we can trust that mission will be put over margin, or at least balanced with it in some kind of palatable way, right? That's a big piece of what it means to be trustworthy in healthcare. You are what you won't do for money. That was a headline to a Ryan Holiday article I read recently and wrote down because, right now, it's one thing for each of us listening here to contemplate mission and margin, and that matters. But it's quite another thing for this contemplation to happen at scale, at status quo consolidated health systems, carriers, many status quo not transparent brokerages, PBMs, TPAs, status quo stakeholders across the board. But because of this, actions being taken at the organizational level may not mirror the mission/margin ratio that you or I might aspire to. So, why this episode with Dr. John Lee, you may be wondering? How did this conversation get teed up for a take two in the midst of this mission/margin tear that I apparently am on right now? Dr. John Lee talks about and gives some advice for individuals in a status quo, not transparent organization, how to find a mission to feel good about. I would also highly recommend listening to the show with Larry Bauer. It's a summer short and it's called Knights, Knaves, and Pawns. So here's my conversation with Dr. John Lee. And next week, come back because I'm going to continue the mission margin conversation with Dr. Ben Schwartz. And it's a really good one. So come back next Thursday too.
Hi, I'm Chris Deacon with Versan Consulting. If you're listening to Relentless Health Value, we already have something important in common. You care about fixing what's broken in healthcare. This isn't just a podcast I tune into. It's one that I revisit, reflect on, and highly recommend. Stacey's conversations don't stop at the mic. They spark ideas, challenge assumptions, and fuel the work so many of us are doing to fix healthcare. If you're here for real change, you're in the right place. Subscribe to the podcast, sign up for the newsletter, and let's keep the momentum going. Thanks for listening.
Let's say a person believes they want to do well by patients, but their performance review depends on, as just one example, making care less affordable for patients. But somehow, this individual is able to conclude that what they're doing is a net neutral or a net positive, despite, in this hypothetical, let's just say, obvious indications that it is not. In this hypothetical, there are, say, clear facts that show that what this person is up to is indisputably a problem for patients, but yet at every opportunity, this person talks about their commitment to patients. This rationalization, or earmuffs, don't look, don't see, is cognitive dissonance. Cognitive dissonance is when what someone winds up doing, their actions, are in conflict with what they believe in. Now, it's harder to engage in cognitive dissonance the closer you are to patients because you see the impact up close. Unless these at-the-bedside clinicians enjoy a robust lack of self-awareness, those who are seeing patients don't a lot of times have the luxury of pretending that what is going on is good for patients when they can see with their own two eyes that it is not good for patients. The further from the exam room or the community, however, the easier it is to not acknowledge the downstream impact. If you can even figure out what that downstream impact is. Sometimes it's legitimately difficult to connect the dots all the way down the line to the customers, members, or patients. Today, I am talking with Dr. John Lee about what to do in the face of all this when working in the, as I call it, the belly of the beast, working for a large healthcare organization such as a hospital. Because hospitals sometimes, and we certainly do not want to put all hospitals in the same category, they are a wildly diverse bunch, but sometimes some people at some hospitals do some things which are not things I think they should be doing anyway. They're fairly egregious breaches of trust, actually. But yet within that same organization, you have doctors and other clinicians or others who are working really hard to serve patients as best they can. This is the real world that we're talking about. And the question of the day is, so now what? When you are a person not suffering from cognitive dissonance, at least to the level of those around you, what do you do to not get demoralized? And look, while it would be amazing if someday we build a whole new health system that didn't include some people doing things that I don't think they should be doing, that day is not today, and it's not tomorrow. I'm going to hope that there's other people in our village who are full on doing the disruption thing. But if we're not able to do that personally, for whatever reason, but we still want to inch forward within the existing environment and do the things that make us feel like we're achieving our mission, what's the best way to think about this? That is what I asked Dr. John Lee, and that's what our conversation is about today. Summing up his advice, which is really good advice, Dr. Lee talks about how it's so important to celebrate the small wins and feel good about care that is a little bit better than it was 6 months ago. He talks about incremental improvement that helps both patients, but also colleagues. And that's not insignificant to really consciously consider how to work together and help to support each other. Dr. Lee's last piece of advice, it's really important to seek out like-minded individuals as sounding boards and as a support network to commit to supporting each other. And I hope all of you that you feel like you found your tribe here at Relentless Health Value. You guys are an amazing bunch. So know that and don't hesitate to reach out to each other when you need help. Dr. John Lee is an ER doc, emergency room doc by training, who is also an informaticist and chief medical information officer. I can tell you from personal experience that Dr. Lee is one of the most creative and pragmatic problem solvers that I have encountered. In the conversation that follows, Dr. Lee offers a really nice array of examples of incremental in the belly of the beast stuff that might be possible in the real world. So without further ado, my name is Stacey Richter, and this podcast is sponsored by Aventria Health Group. Dr. John Lee, welcome to Relentless Health Value.
Thank you so much for having me. This is the highlight of my day.
Well, it is the highlight of my day to speak with you, my friend. Why don't we just start out with, if you're thinking about cognitive dissonance, how do you think about it? What is it?
There's a lot of rhetoric saying we have to change how we do things. Once people who buy into that get into the system and try to change the system, particularly from the inside, they're often overwhelmed by the tide of the momentum continuing to push the system in essentially in the same way that it has been continuing to go for the past several decades. The cognitive dissonance that you're describing is the feeling that I wish we could do more, but the system just won't let us. And there's many people who've talked a lot about this, but just from a personal perspective, it sometimes can be very frustrating. And one of the reasons why I gravitated toward your podcast, because it was a different tribe that I could feel like I could belong to, that at least maybe I can't make that sort of grand scale impact that I want to make, but at least I can be surrounded by other people who are of a like mind.
Well, I appreciate that. And that is actually a goal of the podcast, to provide a sort of community that can wrap around and give some bolstering and comfort to those who may feel very alone for maybe the reasons that we can talk about right now. You have a system that, after all this time, very fee-for-service oriented.
There was this one presentation given by an internal medicine physician, and he and his team stood up a really, really good heart failure program. And they were really successful. They were really successful in reducing the number of hospitalizations that these heart failure patients were having by almost like a third or a half or something like that. And it was a fantastic presentation. I went up to him afterward, congratulated him, shook his hand. And his comment afterward was, yeah, I didn't want to say it during the conversation. He looked a little bit downcast. And he said, yeah, we have to actually sunset this program because it is too successful. The commentary that he made was that my CEO told me that we have to stop the program because it's reducing heart failure admissions too much. It's costing the hospital money. And actually, I just recently listened to your podcast with Scott Conard, who talked about how in a similar way, in a larger sense, his clinics were so successful that the healthcare system bought his clinics and then shut it down because they were reducing the number of hospitalizations. That's the sort of cognitive dissonance that is so frustrating to people who want to try to actually improve our system.
So here you are, and here the doctor who set up that heart failure program was. Here's Dr. Scott Conard. There are so many examples of great clinicians and very mission-driven individuals. Rob Andrews also talked about this on the show, wherein the way that the money flows right now, you don't get paid a lot for preventing anything. 1% of heart failure patients are on optimal medical therapy in this country. I can cite stats like that off the top of my head because I was so shocked.
Yeah. And I would say that the sorts of conversations that I had with that internal medicine physician is probably more an exception rather than the rule. Most healthcare systems are just obliviously ambivalent and satisfied with doing things the current way that they're doing it.
Well, it's interesting because I also was at a physician summit a couple of years ago, and I listened to a doc who also stood up a heart failure program to prevent readmissions. And it was also very successful, and it also got shut down. And there was more money in those readmissions than in the paltry CMS fines. Actually, the show with Dr. Rishi Wadhera gets into this in depth. So for sure, you definitely have system level factors that start pressing down on individuals.
But so I know of many of my colleagues who are very focused on RVUs and the volume of services that they produced. But I also know that they're really good docs who really, really care about their patients. But they're existing within an environment that just induces that sort of behavior so that it's less of an issue where they're not trying to game the system, but the system has almost gamed them. And you can't really blame most of the people for doing the things the way that they're doing them. And what we have to do is try to actually change the system. But a third of healthcare waste is somebody else's profit. That profit buys a lot of influence.
Let's talk about how these systemic pressures really press down on individuals. So if I'm just making a list of things that create this cognitive dissonance, it's the way that comp models work. You mentioned RVUs.
Yeah, let me kind of paint a picture of something that has been a theme, particularly among some of my ambulatory and primary care-based colleagues. They are constantly being pushed harder and harder to see more and more patients to increase that volume-based revenue. It all just becomes like you're a CPT RVU machine. And I think from a technology perspective, there is the ability to actually change that paradigm, to introduce more team-based care, to actually create very proactive mechanisms so that the primary physician who's responsible for a particular patient, he has an entire team surrounding him to support how that physician interacts with that patient, so that if they do have that interaction with the patient, they actually feel like they're actually moving the ball forward and improving that patient's life. Or I guess to use the Peter Attia term, that improve that patient's health span.
There's obviously consequences on both sides of the room there, in which you have a physician who is being treated or feels like an RVU machine, a CPT code machine, as you just said. But on the other side, you've got a patient who's like, I guess I'm a widget too. So we have a system at this juncture that's pressing people into these modes that reduce the human aspect of healthcare, if I'm reinterpreting what you just said. Layer onto that the idea, which could be especially demoralizing to someone such as yourself who can see a way forward, who can see, wow, we could use technology in this way. We could do this. We could do that. There's so many ways that I could see to improve this. And then you have a system that's like, nah, I think not, right? Like I could also see how that would be frustrating to the good people, like the people that wanted to try to figure out how to fix it and no one is interested.
And one of the things that I've sort of migrated to in my thinking is that I'm not going to make that wholesale, massive change. What I can do is nibble around the edges, help things in little ways. And even if I get just a little win, hopefully I will be that one little win compounded with other little wins that other people make as we try to improve our healthcare system.
What you're talking about is working from within the belly of the beast, surrounded on all sides by giant institutions. So for you, the best path forward might be small things that make a difference right now for patients and your colleagues. What works in some situations as we think about bigger and more disruptive is just not going to work for somebody else. It's just not even possible. So what I want to hear from you is, okay, now what? How do you make lemonade out of lemons? How do you contemplate still feeling like you're working in alignment with your values and what you want to accomplish, despite so many pressures? You and I have had some conversations earlier where if you come up with something that you'd like to do, and then there's all sorts of obstacles in the way, you said it's really easy to become disillusioned. And you were talking about how your advice and your mindset then has to be, okay, in the face of what's going on, what can I do? What can I accomplish? So how do you think about the incremental improvements that you can realistically make? Or what are some examples of things that you have done?
One of the things that I'm really, really proud about is I helped create a system that my fellow emergency physicians, they were actually okay with it. Unlike many other colleagues around the country, they viewed the system as pretty well designed. And so that for me was that one little thing, moving the ball forward so that we could actually start digitizing some of the data that our system creates in taking care of patients. And in me helping my colleagues be more comfortable with a digital system, now we've created data. That data can then inform other tools downstream that can help transform the system. That's the very first step. We can't do anything else without doing that. And then another is just coming up with different ideas. Some of them may not stick. So your podcast with Kenny Cole, within it, he mentioned something about metformin and how people stop taking metformin because of gastrointestinal side effects. But I know that how that's documented within the system, it's very different based on who documents it and what system they document it in. If we could somehow encapsulate that as a piece of data that's consistent and reliable across systems or across offices or across practitioners, then you can start aggregating that and then being able to say, okay, these are the things that actually predispose somebody who is on metformin to stop taking it because of gastrointestinal side effects. And then if you can start encapsulating that as a digital picture, then you can actually start putting into place even something simple as, well, we see based on the data that's in your system that you're predisposed to having gastrointestinal side effects. We are going to have somebody call you a week after you start metformin and see how you're doing and see if we can put in some mitigating processes so that you can stay on metformin. But the first step of that is actually encapsulating that as data. And what I did was I took that podcast, I forwarded it on to some people I knew who are very astute data scientists, and they have a way to actually encapsulate that and encode that into something that is very easily digestible by multiple systems across multiple organizations. And that's something that would be really valuable. Now, I'm realistic enough to know that putting that out there and kicking that off, that may or may not go anywhere, but I keep trying because that's my makeup. I want to try to help move the ball forward and use technology to actually improve our healthcare system. And that's the sort of thing that I keep trying to do.
I'm very inspired by you and the initiative that you have when you do stuff like this. It's another thing, but it also might be exactly what is necessary to feel like a difference is being made when you consider how you may help your colleagues. Like, how do I, within my current role, potentially support colleagues who are trying to figure out how to do right by patients, which many are, and you give two examples there. One is in your role at the time, and everybody's going to have their own example of this, but you were tasked with building an ER IT infrastructure. The system that you built aligned with what your colleagues' needs are, not just what somebody dictated from above. So you took the time to ensure that the system that you built was going to work for colleagues as well as the hospital system writ large, which I can definitely see would give a measure of appreciation and pride, rightfully so. And then the second part of this is, what do patients really need? You gave the example of the episode with Dr. Kenny Cole from a couple of weeks ago. He talks about just how many patients fail on metformin because they're actually not taking it properly.
I'm going to come off as a Stacey Richter fanboy on this, but I'm going to quote another episode that you had. I forgot what the exact quote was. You used the Marcus Aurelius quote. Something about being happy with the smallest progress. And I think that's what we have to do. Some of us are big names, have big influence, have big personalities, and can do big things, Mark Cuban-ish type things. But others of us, we have to be able to be satisfied with doing the right things that we feel like we can do and be satisfied with that.
Figure out how to support your colleagues. You can figure out how to support patients in whatever ways. What's your advice for someone who might not have the same job as you?
One of the teams that I used to work with, I would use this metaphor a lot. Our healthcare system, the dysfunction in our healthcare system is like this enormous boulder stuck on the side of a mountain. Just one person isn't going to push that boulder down the hill, which is what we need to do. But what we can do is take the little pieces of pebbles around that boulder. If enough of us are taking out enough of those pebbles, at some point that boulder is going to start rocking. And then once that boulder starts rocking, at some point somebody is going to be able to push it. And then once that boulder starts rolling, it can't be stopped. Because the things that we need to do with our healthcare system all make a ton of sense. Once that logic takes hold and the things that our patients need align with how we actually deliver healthcare, then it's going to be a force that can't be stopped. I may be being a little bit too optimistic, but that's what I truly firmly believe.
That's a wonderful way to put this, exactly like you just said. If there's a boulder and we each just take a pebble, then we can really create change in an organic way, even if it's not necessarily some kind of formal collaborational alignment. That if each of us just thinks, what can we do? What are the simple opportunities, I think you've called it, wherein we could make even a small difference. If there's enough people who are thinking that way, inevitably change will wind up happening just because it's almost creating a zeitgeist of a certain kind.
Yeah, absolutely.
And,
that's a great way to put it.
The other thing, here's another word for zeitgeist, a tipping point. One of the things in that Malcolm Gladwell book, if only 12% of individuals are pushing in a certain direction, tipping points happen. It's amazing how word travels, ideas spread, especially if there's enough people who believe something in their heart of hearts and want to see something happen. And I do feel like there's so many across the healthcare industry that realize something's got to give.
We just need to be able to push back against that system. And, to use another metaphor, if this current system is a big river pushing us downstream, as difficult as it sounds, we need to reroute that river so it points in a different direction.
So one of the things that you said was, as we just talked about, Dr. Kenny Cole talked about just how many patients stop taking metformin because of avoidable gastrointestinal symptoms. And that is something that could be codified if we, A, know it because we have the data, but B, we can build something to disseminate that information. But what else? Give us some bright spots here, things that people may contemplate.
So let's say you're a medical assistant in an office and you see the doctor doing all this labor that you think that you could do. Then maybe suggest, hey, maybe we can do this and take the load off your shoulders, doctor, or to the nurse, and feel like you're contributing more. It could probably positively impact how you feel about your being part of the team and contributing to the patient's care, also making the team more effective and efficient. The other thing is to start identifying places where there are waste. And they're all over the place. That sort of identification and the reporting and trying to execute on that sort of observation, that's an entire project altogether. But at least start maybe taking that and injecting kind of that culture of, we shouldn't be really doing this, or there's a different way of approaching this. Why is that printer way over there 20 feet away from the computer when everybody goes to that printer for every single patient as we print stuff out? Little things can add up to a lot.
Those are some great examples that have just so much packed into them. One of them is just make a suggestion. And it's in a way, a commentary on the healthcare system today, that even comes up. We've gotten ourselves into a place where we talk about team-based care, but we have to bring up if someone sees something that could be improved, maybe we should talk amongst ourselves.
Yeah, the unfortunate reality is that there's a lot of healthcare systems, maybe even most of them, that are very hierarchical. The doctor or the C-suite administrator says, we have to do it this way, and people have to kind of march in line. I think it would benefit our healthcare system writ large if we weren't like that as much, that if we could actually incorporate the sorts of suggestions or input of the entire team. And this is almost an organizational extension of the concept of team-based care around a particular patient, but team-based care from an organizational perspective. I just wish that a lot of our healthcare systems would absolve themselves of the top-down hierarchical approach to managing.
Well, here comes Gen Z. And the one thing I've heard about Gen Z is they really don't like hierarchy very much. But in a way, a command and control environment is somewhat antithetical to team-based care. Having teams wherein the team feels afraid to speak up and make suggestions because the hierarchical, like those that sit above them are going to lash out. Like, there's a lot of consequences.
Yeah, it's in their best interest to promote that sort of stuff.
So maybe contemplate what's the environment. Is there any influence that you might have on the environment that could enable people who are trying to do things in a better way or who may have insight into how to improve? Can they feel like they can speak up? That's number one. Or number two, if you see something, maybe say something. And I'm not sure if you have any advice for if someone is working in the hierarchical environment and they do see something and they want to say something. I was chatting with Ann Richardson the other day, who had just one example after another of times when someone brought up something that was a potential patient problem or was a patient problem. And the response of the system was actually to blame that individual for the problem. And wow, my heart just started to bleed for some of these really mission-driven people getting their faces smashed against the wall for daring to do the right thing on behalf of patients.
Well, that's an entire discussion altogether. I mean, whenever I think about this in the recent history, I consider the RaDonda Vaught story. She's a nurse sedating a patient, I think for an MRI, and there were two medications. One was vecuronium, which is a paralytic, and the other one was Versed. And because both of them started with VE, they were close together in the medication card. She was supposed to give Versed to sedate the patient. She gave vecuronium, which paralyzed the patient. The patient died. She self-reported this mistake, and then she was criminally prosecuted for doing this.
This was recent. We'll link to that in the show notes.
But this is the sort of thing that needs to stop. Yes, tragic. Yes, she made a mistake. But I can almost guarantee you that at least one, probably more nurses almost made that same mistake, but they didn't report it. Phew, that was a near miss. I'm going to get on with my day. But imagine if they had reported that, and then there were like 3 or 4 reports of that. Somebody noticed and said, ooh, that would be a really bad mistake to have. So let's systematically try to create, rearrange the medication card or do something so that that sort of mistake can't happen in the future. Then that patient wouldn't have died. That nurse would not be facing a prison term.
Wow, that is so horrific. You really have to think through the outcome you're trying to create. Is it to prevent additional deaths or punish a nurse who reported her own mistake? Because in a way, maybe we have to pick one because we can't have both.
So this kind of goes to this larger discussion that we're having. This big system is pushing everybody in a certain direction. I can understand how somebody who's, say, a medical assistant who sees something doesn't want to speak up, or they don't feel empowered to contribute to the team. And I hope that people start doing that a little bit more.
So if we're thinking about constructing our pieces of advice here, the first piece that we talked about was really contemplative of what do patients need? What's going to help? Second one is, how do you support colleagues? Thinking about both of these two things simultaneously, you had mentioned waste. Where is there waste within the system that could negatively impact patient care? Example of this, there's lots of people not in exam rooms because they're walking around trying to get printouts. Time is a zero-sum situation. So it's certainly a win-win. In order to achieve either one of those two aims, it does take trying to figure out how to build an environment that people bring up suggestions to continuously improve.
The other piece of this, though, is that you also have to acknowledge that you can't do everything and that there are certain capacity constraints. Even if you suggest that you move that printer, you may not necessarily realize that IT has to come by and they have to rewire all the cables and then they have to remap the printer to, it's something that seems simple, often isn't simple. And so I think as somebody who's trying to do stuff like this, you also have to accept the fact that there are certain limitations on what you can do. There are capacity constraints, and then not necessarily get frustrated about it.
It may be a lot of steps for some individuals, but it's closer for others. So
exactly.
There's this compromise situation. One of the things we talked about team-based care being a part of this and doing things to really support and emphasize the team in the team-based care. So not getting frustrated by that. What's that African proverb? If you want to go fast, go alone. If you want to go far, go together. So the going far together is always going to take longer. But the other one that you had mentioned was the whole idea of moving this whole transformation thing forward. It's bigger than a boulder, right? It's probably planet-sized. So we each have to just be happy with what we actually can accomplish. Like we can't let perfect be the enemy of the good and mental health and just our motivation to keep doing what we're doing on behalf of patients. Let's really feel good about the pebbles that we have pulled out and fixed.
Yes, absolutely. Otherwise, you'll just get frustrated.
I do feel like in a lot of environments, it's the really good, motivated people who are the ones that wind up leaving. I feel like this is a really important conversation to have because it's exactly those individuals, the ones that are listening to this show that we really need to continue to inspire and be inspired in the face of all these contrary forces and just BS, because it's this crew that's going to transform healthcare if anybody's going to do it.
Well, and I think also one of the things that just came to mind is it is really helpful to have like-minded individuals to be able to be sounding boards for other like-minded individuals. One of the things that I would love for you to do is create some sort of mechanism for people to connect and communicate with each other who are of like mind so that I don't feel like I'm the only relentless health value person in my organization. There may be some others. And I've certainly encountered others who have, in some of the work that I do around the country, I mentioned your podcast and they said, oh yeah, I love talking to Stacey. And then that creates almost kind of an instant bond that, yeah, we know what we want to try to do. And we know that we're both frustrated. And we also know that if we get too frustrated, we can count on each other to talk us off the cliff.
That's such a lovely way to put it. And it really just emphasizes the importance of community, just to have that kind of release valve, which could be a conversation with a colleague, either near or far, who is trying to push that same boulder down the hill. Feeling alone is so hard. It takes a village and we all have to work together and figure out how we are supporting each other. And maybe that's something that those of you who are listening to the show can really keep in mind and think about how on somebody's worst day, if we are there and able to say, good on you, keep it up, you're amazing, that really matters. So maybe as our last piece of advice here, it's a commitment to support each other and to keep our eyes open for those who are trying to do better, do right, fix something, to just offer them a measure of our heartfelt support and thanks and appreciation, because that actually maybe make all the difference in the world.
Yeah, absolutely. And be able to have some sort of private mechanism to do that. Because a lot of times you're hesitant to do this in like a public forum, but if you have some degree of familiarity and trust with somebody who thinks along the same lines as you and being able to pick up the phone or text them, I think that will go a long way.
I couldn't agree more. I mean, there's plenty of times where I'm about ready to throw in the towel any day of the week and someone just comes out of the blue and says thank you or much appreciation or this was really meaningful to me. I can tell you just personally how much that really matters. Dr. John Lee, is there anything that you wanted to mention that you didn't have a chance to in the conversation today?
Be happy in the small things. Have conviction in the things that you think you want to do is right, that it is right. keep plugging away. It may not turn around all at once. You may not be that person who pushes that boulder down the hill, but be happy that you may have contributed to taking one of those pebbles out.
Hear, hear. If someone's interested in learning more about your work, where would you direct them?
LinkedIn, probably the easiest place to connect with me.
Dr. John Lee, thank you so much for being on Relentless Health Value today.
Thank you.
This is Dr. Scott Conard from Converging Health, encouraging everyone to listen to Relentless Health Value. Stacey, I listen to your show every week. I can't wait for it to come out, both because I love the people you have on. They're brave, courageous people who are willing to speak out, and that is really challenging in today's political environment. And two, what I learn, and I always learn something. And what comes to me as I listen to this is, who can I share this with? And so I will send the Relentless Health Value link, text it to people and email it to people. And it's amazing to me how people listen, they get turned on to you, and they change the way they're designing their health benefits. They're reviewing their contracts. They're getting their PBM contracts. And it is so exciting to be able to have you in the world doing that, because I don't know of anybody else that has the wisdom and the vision that you're putting forth and bringing the people that you are on your show.